Yes, is that all right? All right, I'm moving you over here. So if I'm looking over here, I'm looking at the screen. And then I'm gonna try and share. Top one, is that what I want? Sure. All right. Y'all can see my screen, I hope?
Yeah, you can see it.
And if I full screen it, does it work, is my question.
Looks good.
All right, cool. You see my little pointer? Great. Hi, everybody. My name is Dan. You can see my name there, low on the screen. I am one of the hematology and oncology fellows. I plan on doing oncology with my life for the most part, so that's why I say onc. I went to med school with Nick, which is how we know each other, which is how he wrote me into this, because he ran into me in the hallway one day and he was like, hey, do you want to talk about cancer sometime? I did residency at Penn, and I was a chief at Penn last year. So as crazy as it sounds, I actually like doing this kind of thing, and it made me kind of excited that Nick asked me to do it. So I heard, and it was true in our residency program as well, that you guys don't get a ton of solid oncology education. And so that's why I am going to talk a little bit about solid oncology stuff today. So we're going to talk about colon cancer. Initially, Nick asked me to talk about colorectal cancer. Colorectal cancer is a lot, and I don't think I can do all of that. So we're just going to be talking about colon cancer today, and only the things you need to know as a resident, or maybe a tiny bit more than that. I will ask some questions. If I don't hear any answers, I'll just go forward. I know that Zoom is really hard to be participatory with, so I'm happy to just like go and talk, but I'd also love if people like chimed in. As you can tell, I'm like a relatively chill human, so I'm happy to just please answer and answer wrong, and that's how we all learn. So with that, let's get started. So today we're going to talk about a case presentation. So we're going to talk about the clinical presentation, physical, labs and imaging, just to kind of frame our entire framework for what we're going to be talking about today. We're going to talk a little bit about inpatient management of somebody who is presenting with colon cancer, acute management in one specific scenario, which will be a reason that some patients present, and what's helpful to do as an inpatient, because I've been on solid oncology consults once already, and I'm doing it again in a couple of weeks. And that's a common question, like, what do we do? What do we do for staging? What do you need as an inpatient? And I'm happy to tell you that here, so you know, it's good for your education. Also, if you don't need to consult me in the future because I've taught you so well, that's not a bad thing. But feel free to consult, seriously. The next thing we'll talk about is how to interpret the pathology, because that's something that's like this really nebulous, confusing thing that I think actually makes sense to know a little bit about so that you can help educate your patients. Specifically, we'll talk about right and left-sided disease and how they're a little bit different, and what the therapeutic implications of the pathologic reports are. And then we'll talk just a tiny bit about outpatient management, about a little bit about staging and how that has implications for therapy, and just a little bit of learning about the different chemo regimens that you should at least recognize the names of and what can go wrong with them. So what we're not talking about today: epidemiology, prognosis, specifics of chemotherapy, surrounding like the duration of chemo, surveillance, recurrent disease, oligometastatic disease, because colon cancer is this weird thing where, like, if you have metastatic disease, you can still be cured, which is really strange in solid tumors. We're not talking about appendiceal cancer, which is technically in the colon, but is a whole different animal. Rectal cancer we're not talking about as well, as I said. So we're not talking about a lot of stuff. I'm going to try and boil it down into something that's really digestible, and hopefully you guys will enjoy it. Please interrupt anytime with questions. I tend to talk a little bit fast. That's because I like to get through stuff so that we can ask questions at the end if you would like to. Cool. So here's our case presentation. 64-year-old woman, and if I'm looking this way, I'm looking at my notes, by the way. 64-year-old woman with a history of smoking presents for constipation and mounting abdominal pain. Started 2 weeks ago, was gradual onset and progressive. She had some early satiety and anorexia starting about a week ago and hasn't been taking in good PO. She sometimes feels like food gets stuck in her stomach, and she vomited once after a large meal. And she tries Zantac with some relief. She doesn't have any bloody vomit or stools. And her physical exam shows relatively stable vital signs with a heart rate that's kind of borderline tachycardic, but technically normal. And then her abdominal exam, which is the thing that you are probably most concerned about, has some mild epigastric fullness, but no true tenderness. These are her labs on presentation. I'm not going to ask you to tell me what's abnormal because you are smart people who are residents and who know this. I'll just point out that she's a little bit hypokalemic. Her creatinine is 1.82, her baseline is 1, and she's a tiny bit anemic as well. And I guess her sodium is borderline low, technically, as is her chloride. And this is her CT abdomen. This is where I'll ask, can anybody tell me what they see? I wish I could, I tried to make it so I could scroll through it, but the program I was using didn't let me do it. And I'll wait for a second to see if anybody wants to participate. If not, it's cool.
Looks like dilated bowel loops. I am bad at, honestly, I think that's large intestine, but I probably want to scroll up and down just to make sure first. But also context clues is probably colon.
Yeah, it is context clues colon, correct. I'm not gonna try and be too mysterious here. So you can actually tell, you can see these little, these make it more likely to be colon here. Blanking on the word for it, it starts with the C, sorry. But makes it more likely to be colon. You're definitely seeing air fluid levels. It's definitely dilated. You can see how dilated it is from like here, oops, sorry, here to here. And that's pretty impressive. So the CT read here was there's a short stenosing stricture with wall thickening at the rectosigmoid junction, concerning for primary left-sided colon malignancy. There's distended fluid-filled large bowel, most pronounced in the right side of the colon, not included in read, but things that are important that there is missing. There are no liver lesions, no lung lesions seen on this CAT scan, at least in the lower part, and no osseous lesions concerning for metastatic disease. So, question is what now, and what questions should you ask? So what is her diagnosis? Or what do you think that she has? She has likely primary malignancy of her colon, and she's presenting like this. So her diagnosis is likely to be malignant bowel obstruction, right? So we know that she has imaging evidence of likely malignancy, and her clinical presentation with constipation for many weeks, vomiting after a meal, not being able to take in good PO is consistent with a bowel obstruction. So there are 3 questions that you need to ask when somebody's presenting with malignant bowel obstruction or bowel obstruction generally. What is the #1 question? This is a little bit of a gimme. I'm hoping that you guys know. And it's a not what am I thinking question, I hope.
Are they able to tolerate any PO?
Great, so that will help you know whether or not they need what's that?
I said depending on whether or not they can tolerate any PO depends on whether or not they need to be inpatient or they need like an urgent decompression.
True, yeah, so GI decompression is one question that you need to ask. I do see something in the chat. I'm gonna try and bring it up. Surgical history, she does not have any surgical history. Sorry, thank you, Rukaya. I did not clarify. Surgical history, but the main question you need to ask with bowel obstruction is especially, does the patient need surgery, which Rukaya was kind of getting at, like, because this is often a surgical complication, but also can be a surgical indication as well. The second question, Andrew was kind of getting at, would the patient benefit from GI decompression? So things like an NG tube set to intermittent suction. Please do not ever set anything to consistent suction. It is bad for people. The third question that I wanted to put out there is it a partial or complete bowel obstruction? I would ask these questions in this order because the call to surgery should be something that is an emergent thing that you've decided right away. And then GI decompression, because that's another procedure that needs to be done right away. And then partial or complete bowel obstruction tells you whether or not you will be able to do things with medical management or what you can do with medical management. So just a word about malignant bowel obstruction. This is different than a regular bowel obstruction because of the etiology of it, obviously. It occurs in 42% of patients with advanced ovarian cancer and up to 24%, so up to a quarter of patients with advanced colorectal cancer. So that's like not a few people. That's a pretty good number of people. So you will see these patients, and the way this patient is presenting with her colon cancer is not a crazy way to present with colon cancer de novo. So these are the 3 questions you need to ask. And so just a couple of words about surgical management of malignant bowel obstruction. Surgery is indicated for certain things with malignant bowel obstruction. Bowel ischemia, necrosis, or perforation. And this is often defined in the literature as fever, peritonitis, SIRS, or pain out of proportion of exam, although that's a little bit hard to measure, and I have some qualms with how they define that in some studies. But imaging showing free air, obviously that's a surgical indication, it's an acute abdomen, and a closed loop obstruction, which should be read as such on a radiology report. Patients who try medical management, but then fail medical management. Usually this is after a few days of failing medical management, but this is a conversation between you and the surgery team to decide what failing means. And then some special cases. So things that you see in kids more, but volvulus and intussusception. These are 2 things that you can see in cancer patients because tumors can create this nidus for pulling the tissue into places it shouldn't be, whether it's twisting with volvulus or kind of telescoping with intussusception. Small bowel obstruction, due to non-metastatic small bowel tumors. So this is basically the patient who presents with a bowel obstruction like a duodenal or gastric outlet obstruction, and they have imaging evidence only of that one spot, and you can say, hey, I can fix both things at once. I can fix their obstruction and cure their cancer. Let's do the surgery. And then complete large bowel obstruction due to colorectal cancer. So what we're talking about with this patient might be an indication for surgery in this case. So there's a large, do I have a picture of it? Yeah, great. So this is a, this is a review called Management of Malignant Bowel Obstruction Associated with GI Cancers that I found very helpful. If you guys are interested, you should look it up. I'll put pictures of the titles of things in case you ever want to look them up, because I find them to be helpful resources. This was a large pool meta-analysis of 43 trials and 4,200 patients presenting with malignant bowel obstruction associated with GI cancers. And with surgical management, which usually was a proximal diversion, meaning they kind of cut proximal to the obstruction and either created an ostomy or bypassed and anastomosed the bowel distal to the obstruction. So after surgery, 27 to 68% of patients had resolution of their bowel obstruction. So again, that's not 100%. This isn't a guarantee, but it is helpful. And the rate of reobstruction is somewhat similar. So it's also 10 to 63%. So somewhere between a quarter and 2/3 of patients will have improvement with surgery, and somewhere between a quarter and 2/3 of them will reobstruct, which is a poor prognostic factor, obviously. Mortality from this ranged from 0 to 32%. So that's actually pretty high, with a high morbidity rate as well. So what I want you to take out of this is surgery is helpful for malignant bowel obstruction. Have a low threshold to consult surgery. They would probably kill me if they heard me say that. But you understand what I mean. And it's a highly morbid diagnosis, especially if you reobstruct. Those are the things I want you to remember. So let's address each of these questions. So her diagnosis is malignant bowel obstruction. Question number 1, does she need surgery? I can see the chat. You can either put in the chat or say out loud if you think if the patient needs surgery. I got no takers. That's okay. So the patient either needs surgery or it at least needs a surgical consult. Because again, the mortality is so high with these patients, and she is presenting with what seems to be maybe a complete bowel obstruction, although you can debate either way. But if there's any question in your mind, you should at least consult surgery, and they can determine if the patient needs surgery or not. Would she benefit from GI decompression? Probably not in this case. She's not actively vomiting. She's not really nauseous. She doesn't have a ton of pain. You can do other things to manage her like GI secretions. And so you probably don't have to drop an NG tube in this patient right away unless she's starting to get worse. And then the third question is this complete or partial? And I think that this patient's probably complete because she hasn't had a bowel movement in so long and is otherwise starting to become symptomatic. So in terms of the medical management of malignant bowel obstruction, it depends a little bit on whether it's complete or partial bowel obstruction, but there are some general concepts that we should talk about. And again, this is how a patient with colon cancer might present to the hospital. So this is what you might see on the Blue 3-4 service or your general medicine service. So there are a lot of places that you can act. This diagram kind of just tells you what the pathophysiology and what the physiology of nausea and vomiting looks like and what the different targets you can hit are. So I'm just going to list them out. The first thing that I list out for malignant bowel obstruction, which is actually not on this chart, is corticosteroids. Sorry, 1 second. Okay, I got a question. Should we be trying conservative management, laxatives, suppositories, enemas before consulting surgery, especially if the patient is passing gas? I'm going to answer that question right after I talk about the medical management and what medications you can use. So the first thing that you can use is corticosteroids. So in malignant bowel obstruction specifically, as opposed to something like malignant bowel obstruction or bowel obstruction from adhesions or from something else, there is a high degree of inflammation by the cancer in the local area. So there's inflammation and edema in the area of the tumor, which is likely causing more of the obstruction than the tumor itself. I can't say that across the board, but that's an important concept to know because you can use corticosteroids to decrease that inflammation, decrease that edema, and improve the patient's symptoms and maybe even help resolve their bowel obstruction. There's a star next to the corticosteroids because if this patient is going to surgery, corticosteroids impede the healing process. And so I would say that you should talk with your surgery team first before prescribing corticosteroids, because if they are taking the patient to surgery, then you should not be giving them as a general rule. The other things that you need to do, you need to stop the GI secretions. So decrease the amount of secretions the patient has. So for these patients who present with malignant bowel obstruction, you can use BID IV PPIs like pantoprazole, like we do in GI bleeds, to decrease the amount of secretions of the stomach acid so that there's less stuff butting up against the obstruction. You can also use H2 blockers. And then anti-dopamine and anticholinergic agents, such as prochlorperazine, can help as well as atropine. But the prochlorperazine is what I typically use most commonly in these patients. I find that, so I put ondansetron, sorry, I'm going to skip opioids for 1 second. I put ondansetron or Zofran a little bit lower because Zofran has a constipating effect that I try to avoid in many of our patients who experience constipation in the oncologic community or in the patient population. So I usually do reach for prochlorperazine first, just so you guys know. That's a personal preference of mine. And then opioids. A lot of people are concerned with bowel obstruction that opioids will create more constipation, and that is true, but you need to control this patient's pain, and then you can slowly wean down on them. So it's a little bit counterintuitive with the ondansetron, but we have a better alternative with prochlorperazine when you're talking about ondansetron, whereas opioids are really the mainstay of pain management for these patients. So other things, ondansetron, you can use cannabinoids, although don't work too well. Benzodiazepines, although that mostly helps them ignore the pain, ignore the nausea. Olanzapine, and metoclopramide. So metoclopramide, just a word about that, and it has a star because this can be used in partial bowel obstruction because it helps clear secretions, but it cannot be used in complete bowel obstruction because it stimulates peristalsis and can again push up against a tumor, an obstruction, and cause like rupture of the bowel. So it's dangerous to give in complete bowel obstruction. So as for Andrea's question, should you be trying laxatives, suppositories, enemas? So those things are good for people who are obstipated because of constipation. This patient does have a ton of probably hard stool behind her blockage, but those things aren't going to do anything to clear the tumor itself, whereas the corticosteroids can help with the inflammation. And that's why I've reached for more these drugs than trying to go the constipation route. I agree with you. For obstipation, I would be doing laxatives, suppositories, that kind of thing. I use soaps and enemas in all of my patients, as opposed to other enemas. If anybody wants to talk about the spectrum of enemas, I can give that talk another time. I had an attending give it to me once, and I've recreated it, and it's great. But for this patient, for malignant bowel obstruction, go for these medicines rather than your obstipation management. Any questions so far?
What's your dosing for corticosteroids?
So yeah, good question. So you're going to use Dex, and you're going to use a lot of Dex. So usually it's 4 to 8 milligrams BID, and I give it IV because you want these patients to be NPO. So you actually are giving a good amount of dexamethasone, a good amount of steroids. It's a great question.
Perfect, thank you.
So the reason that we're consulting surgery is because we're worried that is A, to see whether we can just remove the tumor, and B, because we're worried about like complications of obstruction.
Yes, that's right. Because sometimes with malignant bowel obstruction, if it's not just the inflammation, if it's the tumor that's blocking off everything, the only way to fix that is to remove it, because you're not going to shrink it really fast. There are very few tumors that shrink so fast that you wouldn't need surgery for this, right? Like small cell lung cancer can shrink like that with radiation, but your colon cancers, your other GI cancers aren't going to do that.
So pretty much everything else we're doing while we're waiting for the surgery consult is kind of symptom management.
Yep.
Like there's nothing really, none of these things will really like help the constipation itself, because constipation is the obstruction.
Yep, probably not. Unless it's a partial obstruction, in which case you might be able to get past it and help the bowels improve with things like metoclopramide and corticosteroids. But if it's a complete obstruction, surgery is really your only option. And so if you're considering that, you need to talk to surgery first. Good questions. Thanks, guys. Thanks for participating. It makes me happy. All right, what slide am I on here? All right, I said all the things on my notes without even looking. I'm proud of myself. So now you have this patient, you've given them ondansetron, prochlorperazine, and IV morphine. Seriously, guys, all my residents last year when I was attending were giving people hydromorphone for everything. Morphine's way cheaper. It works just as well, especially for people who are opioid naive. Please use morphine. It's a good healthcare decision. Anyway, sorry. You give the patient these medicines. They're feeling better. You make the patient NPO, although they effectively are already, and consult surgery. And the patient is determined to be a surgical candidate. So she's taken to the OR the next morning for colon resection. So now that she's gone for colon resection, you're thinking, all right, what are the next steps for this patient? So here's where we are. We talked about inpatient management, acute management, and now we're at what's a helpful workup as an inpatient? What do I need to do for this patient who has a new diagnosis of colon cancer? So inpatient workup, the things that we do need, okay, and at the end of this, you guys should, like, you can screenshot this, you can take this, and you'll know forever. You won't need to ask an oncologist ever again, because this is all you ever need, unless there's a question, obviously. But what do we need? In terms of imaging, we need full staging, so CT of chest, abdomen, and pelvis with contrast. Ideally, you would do this prior to surgery, because then you can get a better idea of what the primary tumor looked like and what is surrounding it. Labs, you want a CBC, a CMP, and a carcinoembryonic antigen, or CEA, which you guys are probably familiar with. The CEA, you should get prior to surgery as well, because as soon as you take it out, it actually has a pretty short half-life. Your CEA is going to drop real quick. So the CEA is important because it helps us know when we're monitoring for recurrence in the future. If the CEA starts to rise and we think the patient doesn't have any cancer anymore, then we have this inclination or inkling that the patient is recurring. So that's why it's helpful prior to surgery. But that's it in terms of labs. And then a biopsy, which you're getting done anyway, because either someone's getting a colonoscopy, or if in this patient who is obstructed, they're going for surgery to divert and maybe get biopsies while they're in there. If they don't get them while they're in there, then the patient does need a biopsy in some fashion. So what are the things we don't need? Things we don't need. Oh, thank you to Andrew who's asking, should we give PO and IV contrast or just IV since they have a complete bowel obstruction? The patient's going to be NPO. And to be honest with you, if they've been obstructed for this long, the contrast isn't going to get all the way down to the tumor itself. And so I would say just do the IV unless your patient is not NPO for some reason. But for this patient who is obstructed, no PO contrast. So the things we don't need brain imaging as part of staging. We do need it for other kinds of cancers, but not for colon cancer. It pretty rarely goes to the brain, especially without going to the liver or to the lungs first. If the patient is having neurosymptoms, get brain imaging, obviously. You guys have brains, so you know that, but still I have to say it. Often with the CAT scan of the abdomen, the liver might have something odd in it that's probably like a cyst or a AVM or a venous, some kind of abnormality, a vascular abnormality. And that's the kind of time that we need the liver MRI. We almost never need that urgently in the hospital, but if you do see that, then you can get a liver MRI, but otherwise we do not need abdominal MRI imaging. And then a PET scan. PET scans in the hospital cost about 30 grand. PET scans outside the hospital cost about 10 grand. So don't get a PET scan. The only time we're ever gonna get a PET scan is as an outpatient, and if we think that the patient has oligometastatic disease with 1 or 2 places in the liver or lung that we think is resectable, and before we give chemotherapy. So these are the things we do need and we don't need, and that's it. It's as easy as that. So, didn't have anything else on this slide. Cool. So now you've gotten all this workup, the patient is recovering from surgery, they're feeling much better, and the pathology results come back, and the patient is asking, do I have cancer? I know you think I have cancer, but like, did the pathology show it? So this is what the pathology reads. I'm not going to read this right now. You guys can read it silently for a second. It's overwhelming, and I, as a resident, even as a fellow, but as a resident, I find this overwhelming. There's a lot of like acronyms and numbers, and we're gonna go over this kind of piecemeal, but I wanted to kind of prep us for that so that we can do it with some kind of intelligence behind it, because otherwise I'm looking at it and it just all kind of go like morphs together. So what's important in all of this? Why and how do we interpret it? This is where we acknowledge that oncology is an alphabet soup of mutations, molecules, and mystery. I should have like trademarked that, but this is all just confusing. And so let's break it down a little bit in terms of what we're expecting to see and how this meets our expectations. So a little bit of pathophysiology. There is a difference between right-sided and left-sided colon cancer. None of this is 100% written in stone, but there's some general rules that are worth noting, and they affect prognosis and treatment. And so they're important to know, especially when you're looking at the pathology of this. So everything from so as you end the small bowel, everything from the cecum all the way up through the proximal 2/3 of the transverse colon, so up to here, essentially, is from the midgut, and everything from the last third of the transverse colon all the way down to the rectum is from the hindgut. So these two parts of your large bowel are actually from different tissues embryologically, and so they have different pathology in them, and their cells are made up of different things. So you actually see different looking tumors and tumors with different molecular markers based on where it is, whether it's up to that 2/3 of the transverse colon or the 1/3 distal to the rectum. So let's start on the left, which is weirdly on the right. This is from a paper called Difference Between Left-Sided and Right-Sided Colorectal Cancer, a focused review of the literature. I highly recommend looking it up and reading it, although I will try and summarize it briefly now. So just look at left for now, completely ignore right. So left-sided cancers are the cancers we think about. When we think about colon cancers that metastasize to the liver and the things we do colonoscopies for, left-sided tumors are what we think about. They make up about 70 to 85% of all colorectal cancers, and their primary pathology is from a process called chromosome instability. So basically, there's loss of heterogeneity, there are imbalances in chromosome number, and there are these mutations that slowly grow over time. So the left-sided are the slow growers. They accumulate one little chromosome abnormality and then another little chromosome abnormality, and they form these polyps that look more like the tubular villus polyps that we talk about. And those are the ones that we think grow so slowly, you can catch them early with a colonoscopy and you'll be fine. So chromosome instability. The common mutations, these are the cancers that commonly metastasize to the liver and to the lungs. This is what we think about, right? When we think about colon cancer. The common mutations you see here are APC, so that's the familial adenomatous adenoma polypo, FAP. I can't do it, sorry guys. So the APC gene that you see in FAP, KRAS and NRAS, which we'll get to, and TP53 mutations. So the P53 is a very common mutation in this kind of cancer. So these are cancers that more commonly occur in males, and if you are catching them later when you compare it to the right side, it has a better prognosis in later stages than the right side. So then you can think of the right-sided cancers as different. So these are not the colon cancers we typically think about. These follow the microsatellite instability pathway. So rather than the CIN or the chromosome instability, this is microsatellite instability. So these are smaller abnormalities. So these are things like mismatch repair, microsatellite instability high tumors. So if you ever hear somebody say like MSI high, that's what this means. So these are defects in the DNA mismatch repair process. And so you get like this little abnormality in the DNA and another little abnormality in the DNA. And suddenly, because you can't fix them, a ton of them accumulate all really quickly. Mismatch, and that's what makes up this cancer. And that's why you get cancer in this case. So this is what Lynch syndrome is, right? So that's a mismatch repair gene syndrome. This is Lynch syndrome. So while the other one is FAP, this one is Lynch. The common mutations you see in this are MSH3 and 6 and the BRAF mutation that we also see in melanoma. Because there are so many mutations in this, you can think of the right-sided tumors like the ones that look less like your cells. And so if they look like less like your cells, then your immune system looks at them and they say, this is not our body. And so you have a whole bunch of T cells that surround these tumors. And because of that, there are all these T cells around these tumors that are ready to be activated by immunotherapy. And so that's why we use immunotherapy more common, or immunotherapy works better, I should say, in these right-sided tumors. So it's a completely different animal than the left-sided tumors, and they're much less common. And I just want you guys to keep that in mind. Any questions about right-sided and left-sided? I find it interesting, but also helpful. Nothing in the chat. I've put no one to sleep who's on video. Props to you guys. Thanks for that. All right, great. So let's move on. So now let's look at the pathology again. So here's the pathology. I'm not going to read it aloud, but I will in a second. But now that we have this idea of what we can expect, either chromosome instability or MSI high, let's delve into it a little bit. So the top part says sigmoid colon adenocarcinoma. So that's a left-sided colon adenocarcinoma. That tells us where and what it is, which helps us in terms of what we're treating, I guess. Makes sense. I completely ignore that first sentence because unless they tell me that there are these other things that are inconsistent, the CDX2, the CK20, negative for CK7, all of that stuff is just to tell them that this is a colon cancer, and we already knew that. So I ignore that for now, unless something gets more complicated. Tumor invades through the muscularis propria, T3. So this is part of TNM staging, which you might have heard of, tumor nodes and metastases. This helps us know the stage. So it's T3 as a tumor. KRAS, NRAS, and BRAF, which are three of the mutations which I just mentioned, are negative, and we'll talk about that on the next slide. The poorly differentiated morphology or grade 3 histology is bad. That's all I want you to know. If it's higher grade, it's bad. Margins are uninvolved. That's good. Lymphovascular invasion is present. That means it's high-risk disease, right? So that means that the tumor is kind of invading into or next to at least the lymph nodes and the vasculature in the area, and that makes it high risk. That's all I want you to know. The same is true of perineural invasion, but in this case it's absent, which is good, but the patient is already high risk because they have lymphovascular invasion. The nuclear expression of MMR on IHC reveals no deficient MMR protein. So it's not MSI high, it is stable, MS stable, microsatellite stable, which makes sense, right? We talked about that as being a pathology of right-sided disease, and this is in the sigmoid colon, which is in the left side. So we know that, and that makes sense. And then there's metastatic disease identified in 4 of 13 examined lymph nodes from surgical specimen, which makes it N2. Again, this is part of the TNM stage, and this makes it N2. So in summary, I know that this is a lot, but if you just take those green parts and break it down, we have a node positive, high risk T3N2 colon adenocarcinoma. That makes it stage 3B. I don't want you to know that. I don't even know that. I have to go looking at like the NCCN guidelines to tell me what T3N2 correlates with. But just so you know, you can look it up. T3N2 means stage 3B. And it doesn't have any of the 3 main mutations we have to worry about. And it's MMR proficient, which makes sense. Does that make sense, or is that way too overwhelming and I went into way too much detail because I got excited? I see some shaking of heads and thumbs up. Thanks, guys. Somebody's outside. Props to you. Great. So we have a node positive, high risk, stage 3B colon adenocarcinoma. So what do we do with that information? Sorry. Why are these markers important? So these markers that we talked about, KRAS, NRAS, BRAF, and the MSI stuff, the MMR, MSI stuff, this is important because it tells us about the biology of the tumor itself. And this is how we are starting to treat cancers now, right? Like you see commercials for Keytruda on all the time because everybody's watching TV because we're in quarantine. We have nothing else to do. We don't have any friends anymore. And you see all these commercials for Keytruda. And that's because Keytruda has now been approved to treat any cancer that is PD-L1 positive. And so we're starting to now treat the markers on these tumors, the biology, rather than where they are, which I think is really cool. So I just wanted to say that, and I'm a nerd and I'm sorry. But most importantly, these markers are relevant for metastatic disease, which is not this patient. KRAS, NRAS, and BRAF. If these are mutated, you cannot use the EGFR antibodies, which are cetuximab and panitumumab. I don't expect you to know this, but just know that it tells us what treatments we can give. The BRAF mutation is seen in only 10% of tumors, and it's mutually exclusive with RAS. So basically, if you have a BRAF mutation, then your KRAS is going to be normal. But it's not all that important, but I find it interesting. And it means that your treatment is going to be totally different because you're going to use a BRAF inhibitor. And MMR, as we talked about, this is an entirely different lecture, and I'm not going to go into it, but if MMR is deficient or the patient is MSI high, microsatellite instability high, more commonly right-sided tumors, you can use immunotherapy. So these are important for metastatic disease, but I wanted to mention them because it relates back to that pathology we were talking about and how to read the pathology and educate your patient about their results. So now your patient's like, all right, I have cancer. You told me I have cancer. So what chemotherapy am I going to get? And how long do I have to get chemo for? And how often do I have to come to get chemo? And will I lose my hair? Will I be nauseated all the time? Am I going to be fatigued? Am I not going to be able to get out of bed? And they're very anxious and concerned. And so I want you guys to be able to at least recognize how this patient might be treated so that you can educate them with just like a couple of facts. So we're here now. So we went through inpatient management, interpreting pathology. Now we're at outpatient management. We're going to talk a little bit about stage first. So I think that it's helpful in cancer to talk about there's surgery, there's chemo, and there's radiation. And when do we use this stuff, in what order? And for colon cancer generally, the paradigm for treatment is if you're not metastatic, use surgery, and then you do adjuvant therapy, or you don't do adjuvant therapy, and then surveillance. Can anyone tell me what adjuvant means? If not, I'll just say it. But
chemo after surgery.
Great, yeah. So adjuvant means after surgery, whereas neoadjuvant means before surgery. What's the purpose of adjuvant chemotherapy?
Effectively to clean up anything you might have missed or seeded in the process.
Yeah, and the long-term version of that, which that's totally right from a histologic point of view. The long-term version is to prevent recurrence. That's what we're trying to do with adjuvant chemotherapy. So when your patient asks, am I going to get chemotherapy after surgery? You say yes or no, because we're trying to prevent recurrence. So thank you, that was great. So the only thing I'll say is that there are some patients with colon cancer who get neoadjuvant or prior to surgery therapy, and that's if the tumor invades other organs. So if this patient had their tumor invading their bladder, we might give neoadjuvant therapy so that it pulls away from the bladder and makes surgery easier, but that's pretty uncommon. So the only things I want you to take out of this are stage 1, 2, 3, and 4. Stage 1 is based on your tumor. If your tumor, T, is superficial, you observe the patient. No chemotherapy. You just observe them and surveil them. Stage 2, if your tumor goes past the muscularis propria, they're either going to get chemotherapy or observation as based on your risk. And so this patient had a high-risk disease because they have lymphovascular invasion. So if they had stage 2 and they didn't have any lymph nodes, they would likely be getting chemotherapy because they're high risk. Stage 3 is N, right? So it's based on the TNM system, TTN. So if you have nodes, you're getting chemotherapy for sure. And stage 4, metastatic, you're definitely getting chemotherapy, probably with targeted therapy and immunotherapy. So these are the things that I want you to remember. And I have probably 8 minutes to do this. I'm gonna just get it in there. Nick, I started 8 minutes late, and you see how that bites me in the butt sometimes. So there are really only 2 options for adjuvant chemotherapy. So when your patient asks, am I getting chemotherapy? It's easy to actually remember in colon cancer because there are really only 2 options unless they're metastatic, either FOLFOX or CAPOX. And this is a lot of stuff and I don't want you to remember it. But when I was in residency, I had no idea how chemotherapy was given. And at the beginning of fellowship, I had to learn it all essentially in a week because I sounded like an idiot in clinic. So each of these is given every 14 days. The 5FU in FOLFOX is given as a fanny pack. So a patient has to get an infusion for 46 hours. So you're going to tell the patient they're going to get a fanny pack if they're getting FOLFOX. So there's 5FU leucovorin, which is only given if you need a bolus of 5FU. I'm not going to go into that. And oxaliplatin, so a platinum agent. And that's 1 day every 14 days. And they're going to get a fanny pack for 2 days. So basically you start on day 1, you get the fanny pack for 2 days, the fanny pack comes off, and then 2 weeks later, you get it again. And you're gonna get that every 14 days. CAPOX is similar. Capecitabine is just a basically pre-drug or pro-drug, I should say, of 5FU, and it gets made into 5FU in your liver, but it's an oral pill. So either the patient's gonna get the fanny pack or they're gonna get pills, and that's what you can tell them, either fanny pack or pills. And again, this is every 14 days, you're going to get the infusion of oxaliplatin, and the pills you do 2 weeks on, 1 week off. There are many variants of the dosing of these, but the things I want you to take away, so ignore the left side of this, is that their infusions are every 2 weeks, no matter which one this is, which one you do. So you can tell the patient you'll be in the infusion center every 2 weeks. You're either going to get the fanny pack or you're going to get pills, depending on what you and your doctor decide, because admittedly, these are pretty equivalent. Generally, the treatment is for 6 months. Adjuvant therapy in colon cancer, as long as it's not metastatic, is for 6 months. You can do some patients can get 3 months of CAPOX if you're low risk stage 3, but generally speaking, you'll get 6 months of therapy. If you're over the age of 70, you're not going to get the oxaliplatin, so you're just going to get 5FU alone, still every 2 weeks and for 6 months. And here are the side effects that I want you to know. 5FU can cause nausea, diarrhea, hand-foot syndrome, and cytopenias. Hand-foot syndrome is palmar-plantar erythrodysesthesia, and it's basically turning red and scaling of the hands and of the palms and the soles. This is something we just tell patients they're going to need to use moisturizer for to prevent. So nausea, diarrhea, hand-foot, and cytopenias. Capecitabine causes a lot of diarrhea. That's the primary one. So it's just like 5FU, but you're taking it orally. So it's already in your GI tract, so it's going to cause a lot of diarrhea. Hand, foot, nausea, and cytopenias, same as 5FU. And oxaliplatin can cause neuropathy, especially cold neuropathy, as well as cytopenias. The thing I remember most from these last 6 months seeing GI patients is that a patient who came in and said, I tried to drink a Coca-Cola and my throat was killing me. It hurt so much because it was cold. I just took it out of the fridge and it really hurt. So cold neuropathy with oxaliplatin. And these patients generally, they can maybe have a tiny bit of thinning of their hair, but they don't lose their hair. So you can educate your patients that they might feel some nausea and vomiting, which can be treated with medicines like prochlorperazine and dansetron, but they aren't going to have any hair loss. Now, a word about colon chemotherapy for metastatic disease. If you think we have time for this, you're insane. This is what the algorithm looks like. It's like, I want to point out, here's bevacizumab, here's cetuximab and panitumumab, and here's pembrolizumab in the first line. And then there are all these different ways that you can do this, and we're just not going to talk about that today. It is more common for a patient to present with non-metastatic disease. That's why I focused on that today. So we're here. We talked about case presentation, inpatient management, right and left-sided tumors, how to interpret pathology. I didn't change the slide. Right and left-sided tumors and therapeutic implications, and then outpatient management about staging and being familiar with chemo regimens. So this is the summary slide. I didn't write what we talked about. I wrote like actual points. So I hope you find this helpful. Malignant bowel obstruction, get surgery involved early, especially if you know it's a complete obstruction. Decide on need for GI compression. Then the medical management I listed out there, especially with steroids at number 1. Inpatient workup for new colon cancer, including CT, chest, abdomen, pelvis, CBC, CMP, CEA, and biopsy, and that's it. And then no to the other stuff unless there's a good reason for it. The pathology, we talked about what things to look at on the pathology report, and then what left-sided and right-sided tumors mean and how they're different. And then outpatient treatment, including what the staging looks like, with stage 1 being superficial tumor, stage 2 is deeper invasion, stage 3 is node, stage 4 is metastatic. Adjuvant treatment is going to be 3 to 6 months of either FOLFOX or CAPOX, and the main side effects I've listed there. Are there any questions that I can answer for you guys? Otherwise, thank you so much for having me and dealing with my excited way of presenting.
It's more of just a curiosity question. I think I texted it, but do you see more right-sided tumors in patients on immunosuppression?
No.
Okay.
It's right-sided tumors are more common in women generally, but I think that is the only like demographic that you can really women and people with Lynch syndrome. But I think that those are the only populations where it's actually higher incidence.
And do you, in general, see more colon cancer in immunosuppressed patients? Basically, I'm trying to find a way to motivate my primary care patients to actually get a colonoscopy.
Well, what you can do is you can tell them, would you rather have 3 to 6 months of chemotherapy or lifelong chemotherapy? Because if you find it late, don't scare them though. I would actually say that, you know, the newer like Cologuard and things like that are making it a little bit more accessible to people who are not interested in colonoscopies. Colonoscopies are great, but Cologuard is good if you can't do anything else. So
this might be a dumb question, but I thought Cologuard was better at detecting left-sided.
It is, yeah, because what it's looking for in the DNA are the abnormalities we know about in the left-sided tumors.
So look for the
again, that's 70 to 85% of all colon cancers we see. And so you're missing some proportion of your colon cancers, but in populations where it's less common, people who don't have a family history, people who are men especially, Cologuard is probably like not just as good, but a good option for them.
Thanks.
Mm-hmm. Any other questions I can answer, guys? What questions do you have I should ask? Thanks for sending in.
Thanks.
Thanks, Dan.
Thanks for having me. Yeah, absolutely. And I'll see you guys on the wards at some point. Take care.
Thank you.
Mm-hmm.